Leeds. Simon is an associate professor of child health research with an incredible amount of experience and wealth of knowledge in conducting qualitative research with young people with lived experience of chronic health conditions. And we're really thrilled to be able to for him to come and share his research with us. He heads up a number of research initiatives and groups at the University of Leeds and is affiliated with their children's hospital there, particularly looking at qualitative research as well as child health outcomes. And without further ado, I'm going to hand over to Simon now, who will be presenting today. Thank you, Simon.
Thanks, Jo. Yeah, hi everyone. Great to be here on the other side of the world, talking about some of this work. It's really interesting just in the kind of conversations I've had in passing with people to see some of the similarities of some of the things that we find in the UK, in our school and health systems, and sort of talk to you about some of the things that you're finding here and see a lot of parallels, which is quite reassuring really in lots of ways. But yeah, so as Jo said, I'm Associate Professor of Child Health Research at the Institute of Health Sciences, the University of Leeds. So I'm going to talk to you today about the INSCHOOL Project, which is the main project that I'm leading. I'm investigating and documenting the school lives of young people with long-term health conditions. So let's get these moving. So the overview of the session today, I'm going to give an overview of the INSCHOOL project. I'm going to touch briefly on some of the methods that we've used, but I'm going to talk more about these in a talk on Friday. And if people want to know more about them today, you can ask me afterwards. I'm planning to leave some time so we can have a bit of a Q&A, and we have a paper specifically about the methods. So if anyone's a methodologist and is interested, then let me know. I'm going to talk mainly about the qualitative findings from our large-scale qualitative project that we ran last year, and talk a little bit about the implications and the future directions for this work. So long-term health conditions, all the references for this slide can be found in the paper that we've had published last year. So definitions of long-term health conditions vary. That makes the statistics that we have quite inconsistent. What counts as a long-term health condition, different in different areas, different depending on your particular professional orientation. The definition that we've been using in our project is a disease of long duration, generally slow progression, or a condition requiring ongoing management over a period of years, which can be controlled but not cured with use of medication and other therapies. So that's quite a broad definition, and we're trying to be as inclusive as possible about what we consider to be a long-term condition. So estimates in some countries say that up to 30% of children and adolescents have a chronic health condition under this kind of definition. In the UK, that equates to approximately 1 to 1.7 million young people, and we worked out about 3 to 4 people in every classroom in schools across the UK. So that's actually quite a high percentage of young people who have some kind of long-term health condition. Recent studies have shown that young people with long-term health conditions are at greater risk of comorbidities and associated mental health difficulties, and have reduced educational attendance and attainment overall as a cohort. Although a recent systematic review last year did find limited evidence supporting the association between absences and attainment for this particular cohort of young people, so interventions that specifically address attendance, which is a big thing in the UK at the moment. Attendance is one of the prime issues in the UK, but interventions addressing specifically attendance are likely to not be effective for improving kind of outcomes for young people with long-term health conditions as a cohort, which is an interesting recent finding. In the UK, schools have a legal duty to look after children with medical conditions. And one of the main ways they do this is through individual healthcare plans. But what we find when we speak to young people and families is that not everybody who has a long-term condition has an individual healthcare plan. Only really those who flag with special educational needs or disability under our sort of SEND umbrella have individual healthcare plans. But the majority of young people fitting this definition do require individual healthcare planning. Those who do have it, it's very sporadically applied. It's very rare that young people are kind of actively engaged in the process of creating these individual healthcare plans, and the way they address their needs is very hit and miss depending on schools and conditions, individual circumstances. So not a very systematic process at the moment. So the INSCHOOL project overall, so it's part of an NIHR fellowship, which is now, once I land back in the UK, I'll be 3 years into the 5-year programme. And we were looking at answering 2 main research questions. So what impact do long-term health conditions have on the school lives of young people? So the 2 work streams that are addressing this specifically, we conducted a qualitative evidence synthesis, systematic literature review, and then a large-scale qualitative data collection project, which is what I'm mainly going to talk about today. In the process of recruiting young people to the qualitative project, we realized there was a huge unmet kind of need in terms of parents and parents' involvement in navigating school and health on behalf of their young people. Every time we spoke to parents to try and arrange interviews, they were overflowing with things they wanted to tell us about their own experiences. So we got some additional funding for a parent project where we interviewed proportion of young parents of young people who were in our qualitative study. So the second research question I'm looking to answer is how can we accurately measure this impact so that we can plan and evaluate meaningful interventions? When I was planning the fellowship, I was looking for a measure that we could potentially use. Oh, hang on, we've got an interloper. Okay, I was looking for a measure that we could use to sort of evaluate interventions. So there's quality of life measures, there's school measures, there's measures of healthcare, but there's nothing that specifically brings all these things together that I could find. The school measures not specific to health, the health measures not specific to school. So we were looking at how we could accurately sort of develop something to fill that gap. So the plan for the INSCHOOL project was to use the outcomes from the systematic review and the qualitative project and the parent project to form the basis of creating a new needs assessment specifically for school lives of young people with long-term health conditions. And that's where we are at the moment. So the idea is that once we've developed this assessment, it will be a tool that can be used in clinics and schools to flag young people who might have unmet needs, but also a tool that can be used as a sort of pre and post intervention measure for research. Next year, we plan to use this tool to conduct a national survey because there currently isn't a pool of data where you can look at the outcomes of cystic fibrosis versus asthma versus cancer for school life experiences. So we're planning on conducting this national survey ourselves. And I'm really interested in the idea of whether we can conduct a parallel survey in Australia using this same needs assessment. What would we find? Would we find differences for different conditions? Would we find sort of cultural differences? Would some of the items in the assessment work well in the UK, but not in Australia? I'd be really interested to explore the possibility of a parallel survey. And ultimately, the data that we gather from this whole project will give us a really good idea of where we can target interventions and how we can, and a tool that we can use to evaluate those interventions in the future. So that's the overview of the INSCHOOL programme. One of the things that's been really fundamental to the INSCHOOL project before we even put in the application for the funding was to have significant involvement of young people in the design and conduct of the entire project. So when I was developing the funding application, I developed a partnership with Leeds Youth Forum, who are a group of young people who are based at the Children's Hospital who have experience of health and healthcare. So we had an initial agenda setting meeting with them to hear about their experiences. They could feed into our research questions. We identified a lead member who was our kind of go-between and joined the steering group for the project. They helped plan and co-design the methodology for the project, designed and reviewed study documents, designed our logo, which you saw on the previous page. They also took part in some pilot interviews. So before we got started with the main project, 4 of them did pilot interviews so that they could get first-hand experience of what it was like for a participant and then feed back to us so that we could make changes. We did participatory analysis. So when we had the qualitative data, we worked with a group of young people to help us analyze the data, which was fascinating. I'd never done that before, and they gave some really valuable insights that fed directly into our results. We also had young people join us to disseminate and co-present our findings. I didn't have the budget to bring any of them here to Australia with me, but they have presented at local and regional seminars. And we've got this additional participatory research grant which hasn't got a tick next to it because we're still finishing it, to turn some of our findings into initial early light touch resources for school and co-design those with young people. So, and like I say, there's this paper here which details this in a lot more detail, so I'll be able to share that with people. So I'm just going to briefly segue to the participatory research grant. So we worked with the Youth Forum to co-design posters for schools, so to put up around to sort of flag the needs of young people with long-term conditions. So they designed really these 4 posters to hit 4 areas that they thought were important for teachers to know. So they're themed around sort of listening to young people, so believing them if they're in pain, asking them questions, acknowledging them. To understand them, so to not assume they can or can't do something, to encourage teachers to look at resources and research about the needs that young people have. To put some of these things in place, so accommodate their needs, provide reasonable adjustments, and then to check in with young people to see how well these kind of interventions are landing with young people, how well they're meeting their needs. So these are very much first drafts, which are just the first time I've ever put them up anywhere. So we're going to work with schools to see if they can sort of make some use of these. So I mentioned the first work stream was the literature review. So we reviewed, we were looking for any papers where there was qualitative research looking at the school lives of young people with long-term health conditions. So we ended up with 36 papers that we'd identified spanning 15 countries. Interestingly, 10 of those, so nearly a third of those papers were from oncology. And there's plenty of health conditions that weren't represented with qualitative research, where there was no qualitative research done in this area. So my poor research assistant, this was her first job in academia, was to scan these nearly 13,000 titles to come up with this shortlist. But we found that there were 6 key themes in the qualitative data. So it was around keeping up, catching up, and missing out on schoolwork, relationships with peers and the difficulty with building and sustaining social relationships, developing identity and the challenges of developing identity whilst living with a long-term health condition, the tricky balance between normality and difference, so the desire to be normal within school whilst having the differences and the special needs that they have acknowledged. Autonomy, so developing kind of independence in terms of managing conditions, but also requiring the support of adults. And the challenges with relationships with adults within school. So these were the key themes that came out of the literature review. And again, this is published in all open access, so anyone can access these papers, and I'll share them at the end. Also, whilst we were doing the qualitative evidence synthesis, we did a survey of healthcare professionals in the Children's Hospital to get their perspectives. So we had 22 participants, doctors, nurses, allied health professionals from across different long-term health conditions. All of the professionals we surveyed felt that the school lives of their young people who they cared for were moderately to seriously impacted by their health condition. The main issues that they saw in clinic were attendance, challenges with peer relationships, reduced academic performance, and challenges with relationships with school staff. So some of the same themes that we found in the literature, we found in the Children's Hospital as well. The professionals kind of reported real challenges in communicating between health and schools. So there was some clinical areas where they were able to provide letters of support, do reintegration meetings, others where it was a real challenge for them to have the capacity to engage well with schools and start to head off some of the issues they would see presented in clinic. So there was definitely a disconnect between the Children's Hospital and the local schools. Part of the reason for this, from their perspective, was unclear responsibilities. So who had the responsibility for managing the health care of the young people whilst they were in school? Was that the school? Was that the clinicians? How did that work? It was a very unclear process. And I think that quite often left some of these things unattended to because it wasn't clear whose responsibility it was. So no clear systematic approach. There was real kind of enthusiasm for the idea of liaison roles to bridge this gap. So there are these roles in oncology. Oncology is very well resourced within the UK, so there are liaison roles there which do bridge this gap. The majority of long-term health conditions don't have that kind of specific role. So it's left to clinical nurse specialists or particularly engaged kind of social workers to kind of try and bridge that gap for individuals who they're working with, rather than having anything more systematic in place. So the in-school qualitative study, this is the main study that we've done in this project so far. So it's quite a large-scale qualitative study. So we had 89 young people take part, all of whom were recruited through clinical collaborators at the Leeds Children's Hospital, so recruited directly through clinics. And you can see there we were working with 11 different clinics with a range of visibility, severity, treatment intensity, hospitalization. We tried to cover a diverse range of clinical conditions and had a minimum of 5 participants from each of the groups. Obviously, we were never looking to comprehensively cover each group. We were looking for a diverse sample of young people across the whole children's hospital. So young people were invited to take part in either an interview or a focus group. Our young person advisors felt it was very important for them to have choices. Yet some young people were comfortable individually, some would prefer to take part in a focus group. And before they came to the interview or the focus group, they were asked to complete a preparation activity. So they were given a choice of 4 different preparation activities that they could choose from. The idea being that as researchers, we didn't have any research questions, we had no topic guide. So we would ask them to prepare an activity. For example, one of them is a sort of bullseye kind of activity where they put the most important aspects for schools in the center, and then the least important going towards the outside. And the idea is that they would complete that, bring it to us and talk us through it as part of the interview, and the interview would all be led by using that as the stimulus, so that we weren't guiding it as a researcher, young people were guiding it themselves. And that was very effective. Young people on the whole engaged with at least one of those activities, and it really reduced the power dynamic to have it as a young person-led activity. And this really helped us to get first-hand accounts from young people. So all of our findings, we could be confident, came from what the young people felt was important rather than what we as researchers felt was important. And we had these 11 clinics, from people who had very mild nut allergies through to people who had very severe cancer diagnoses. And because this was all participant-driven, we were interested to see what we would find in the analysis. And what we found was there were clear fundamental common needs that all young people had, regardless of which one of these kind of age groups or clinical groups they fitted into. We found that broadly, they all had the same fundamental common needs. And the differences were in terms of how those needs sort of manifested for the young person rather than what those needs were. So that gave us the basis for our analysis. So we did this thematic needs-based analysis. This isn't one of the participants, this is my niece who likes to be in all of my talks, so she'll be glad she's got an international audience for the first time. So we tried to answer this question with our young advisors. As a young person in school with a long-term health condition, what do they need? What's coming out of the qualitative data? So we uncovered these 6 fundamental needs, and the first one being to safely manage my health at school. So the kind of things that were under here were being able to have access to their medication, being able to have somewhere private and comfortable to administer that medication, being able to take tablets in front of people without feeling awkward, being able to manage health episodes and being confident that the people around them in school would have the necessary skills and understanding to keep them safe, being able to come and go from school and accommodate the sort of fluctuations in their symptoms, was something that we saw across all of the different groups to some extent. The second need was for a flexible education pathway. So all of the young people we spoke to had missed some time from school, from 2 years in hospital to the occasional day every month for a hospital appointment. But all of them experienced this cycle of falling behind and then having to catch up, and needing the education system to be flexible enough to accommodate that, but also to accommodate the different needs they might have in terms of concentrating in class or exam provision. This one screamed out of all of the interviews was the need to be acknowledged and listened to in the right way. There was definitely a feeling from all our participants that they didn't feel like overall that staff and peers at school really understood what they were going through with long-term health condition, and that their needs, even when they did raise them, weren't always listened to and acknowledged and acted upon. So it was very important to young people. Sort of linked to that is the need to be included and supported by the school community. So we had lots of examples of young people who were unnecessarily excluded from activities or trips or things they wanted to take part in. But also, even if it wasn't so particular and practical, there was a feeling of not being particularly cared about by the school and not being particularly sort of supported by and sort of valued by the school community as a whole. Need to build towards the future. So this was the kind of thing that everyone's doing at school, which is building towards exams and careers. But the thing that we found specific to this group was building towards transition points. So the idea that when they change school, they change year group, their kind of support systems would carry across to those new environments. And that was a concern that a lot of young people had. And finally, the need to develop attitudes and approaches to supporting emotional and mental health. And mental health, I'm sure it's the same here. Mental health is a big crisis in schools in the UK at the moment. And young people with long-term health conditions have their own particular risks of emotional and sort of mental health challenges. So some of them felt like they needed support to come up with strategies to manage that. Others felt like they had their own strategies, but they just needed those to be respected by, this was something that came out of our participatory analysis. So some of them had those things, but they needed them to be acknowledged and respected by the people around them, and felt like they were often under the surface working quite hard to manage their conditions, but didn't always have that necessarily sort of reflected back to them, which was a great part of doing the participatory analysis, because that's not something we notice particularly as researchers. So these 6 needs provide the structure for the analysis. They're also the basis for the new needs assessment. But I think they also provide areas where we can focus on for interventions, and areas where schools can look to provide support to the most number of young people. So here are some quotes from young people. So teachers made me feel like an inconvenience, something that we heard from a lot of young people. This one in the yellow here is about a young person who was excluded from attendance rewards because her health condition brought her underneath that percentage. And we heard this from a surprisingly large number of young people missing out on these attendance incentives because of their long-term health conditions. This one in the bottom left, a young person who had lost their hair because of chemo and had their hat taken off in front of everybody in school because they weren't allowed to wear a hat in school. And this was a fairly extreme example of something that a lot of young people had, which was not everybody in the school being aware of what they needed, what they were going through. And this was obviously devastating for the young person and for the teacher who didn't realize that was something they needed to be aware of. The top right here is a quote sort of talking about this example of a cycle of falling behind and having to work really, really hard to catch up, and how draining that can be. To the right here is a young person from our dermatology group, which is an example of the sort of challenge of having a very visible condition in school. But interestingly, we also found equal challenges with invisible conditions. So our chronic pain group had a lot of difficulty with justifying why they needed support, whereas somebody with a very visible dermatology condition, that was a barrier to them entering school. So that invisibility versus the visible conditions had their own equal challenges. And then the bottom left is something we heard from some young people about feeling like they were developing their own kind of independence at a different rate to their peers, and found that quite a challenge sometimes when they're interacting with their peer groups. So just some specific examples. They were our general needs. We heard from young people in the diabetes group that managing blood sugar levels was a real challenge. So really impacting their ability to concentrate in school, but also something that wasn't well supported by school and well understood. So I won't read out all of these quotes, but the large quote here is about a young person who was having a hypo episode in school, knew how he wanted to be managed, said how he wanted to be managed, didn't have that accommodated by the teachers around him. So then he kind of lashed out, and then he got into unnecessary trouble. And this was a vicious cycle that we saw in a lot of young people, that sort of flagging what their needs were and not having those met could be really challenging for young people. Mobile phones was something we heard from literally every one of our diabetes participants, that they need to use their mobile phones to manage their blood sugars. They're not allowed to use their mobile phones in school, and that was just a constant day-to-day difficulty for them, that they were having mobile phones confiscated, they were getting in trouble in school, or they were having their use of mobile phones challenged in front of everyone and having to then justify the reasons why they had to use them, but they didn't necessarily want to make a spectacle of it in that kind of way. Passes, a lot of our young people from different conditions had passes for various reasons: to leave lessons early, to go to the toilet if they needed to arrive late, things like that. But although they were good in theory to have them as reasonable adjustments, a lot of young people found that practically using them was really challenging. Yeah. So they would perhaps want to leave the class to go and use the toilet, but the member of staff might be a temporary member of staff, didn't want them to leave the lesson, didn't know why they had the pass. And that could lead to this kind of exposing conflict in front of people in the class. Or like this young person said, she was really glad to have the pass, but the pass was a bright yellow lanyard, and she actually ended up getting bullied for having this bright yellow lanyard that she had to wear the whole time. So lots of examples of well-meaning reasonable adjustments that aren't actually informed by how the young people are experiencing them. We found lots of examples of that. And attendance. Attendance is a huge issue in schools. Lots of people not having their attendance and absences recorded adequately, not meeting the threshold for attendance rewards, but also more problematically, we heard from parents and from young people that they were constantly being chased up by the schools to justify why they weren't in school, and this could build up quite an adversarial relationship between school and home. When I think the young people and the families were quite rightly thinking, well, they know that we have a long-term condition that we're dealing with, so we don't necessarily have to justify every absence, but that was a challenge we saw in a lot of our cohort. And we have a paper specifically about attendance, which I'm happy to share with you. So at the end of each of the interviews, we asked young people for their advice for schools and advice for other young people. So this is a word cloud of the advice that they gave for schools. And more understanding was the key thing. They felt like they weren't adequately understood. Changing the teachers came out. So this is something I'm careful about presenting to the schools audiences. But having more knowledge, you can see there's a general theme here: understanding, having more knowledge, being educated about the different conditions. Things like check-in more was a really big thing in this group and in parents. Actually, quite often the level of intervention that's needed is just to check in with young people and parents and see how they're doing. And that was absent, we found, from a lot of the ways that schools were interacting with families and young people. Just regular check-ins, it was very, very important and wasn't happening. And this is the advice they gave to other young people, which is all very positive and heartwarming, I think. So telling them not to worry and tell people and being confident and not letting it change you was good advice to present back to other young people. So I've mentioned the parent project a few times. So, we conducted a spin-off parent project. So we had 27 parents who participated. They covered at least one of the 11 groups in that sample of 27. And what we did was we conducted the same kind of interviews, and we used the 6 needs framework as our kind of framework for analysis. So we're really interested to see if the parent data mapped onto what we found from young people and where the differences were. And we found that everything the parents were saying mapped onto those 6 fundamental needs. So they're clearly being supported by the experiences that parents are seeing as well. The only thing that was slightly different was parents' view of young people's mental health was different to young people's view of young people's mental health. So parents talked a lot more about seeing the cycles of emotional and mental health turmoil that young people were going through. And the young people themselves didn't really talk about it in that way. They talked about the more proactive ways they're coping or more specific examples of what's happening. But I think the parents really saw this kind of challenging cycle that young people were going through, which is really interesting. We also found that parents are really compensating for the failures of school and health systems to meet some of these 6 needs. So we found lots of examples of ways that parents were plugging these kind of gaps for young people and for schools. And we heard in almost every interview some version of battle. So having to battle with schools to get things done, having to battle with health services sometimes to get the right kind of information forward, but lots of significant advocacy on part of their young people. And this obviously had negative implications for home-school relationships with some of these families where there was this constant battling cycle. It actually makes it a lot less likely that those needs are going to be met and young people are going to be happy and go into schools, is what we were finding. But we also realized that this really exacerbates inequalities because for lots of different reasons, families aren't always going to be in a position where they can proactively advocate on behalf of their young people. So if they're not in that position, that means those young people that aren't in those family circumstances aren't going to have that advocacy. And there's already inequalities in our school and health system. So this was another example of how that could be exacerbated. So that's all of our that's kind of a summary of all of our kind of qualitative data that we've collected. And the next part of the project, which we're currently doing, is developing these findings into a needs assessment. So the idea is that we're developing this school needs assessment specifically for children and young people with long-term physical health conditions. So we are doing this in collaboration with 14 different clinics. So the 11 clinics that we had to start with, but then we've also added epilepsy, obesity, and orthopedics as other long-term conditions who we are working with. So we're interested to see whether the way we've developed the assessment maps onto the young people's experiences from these particular condition groups. So stage 1, which we've completed, is to turn all of the qualitative findings into a large-scale item pool for our potential needs assessment. And then the stage that I've just completed the day before getting on the plane to come here was the qualitative work. So we've been to all of the 14 clinics and shared our item pool with at least 2 or 3 young people and families from the clinics to see what their perspective is, how easy the assessment is to understand, whether they think it will be useful, what items they find are working, not working, that kind of thing. So we've now just completed that. So we've got our final version of the assessment ready to use. So we're in the process of just fine-tuning some of the item pool. But when I get back from Australia, we're going to be starting the pilot data collection. So we're going to hopefully get approximately 20 to 30 young people from each of the 14 clinics to complete the online assessment. That will give us a really interesting pool of data that we don't have at the moment, which will flag where these unmet needs are across the different clinical groups, which we don't have any access to at the moment. And then we're doing a statistical method, which I'm not going to bore you with in too much detail, but it's called rash analysis. So we'll be looking with our data to see how well this assessment functions as a kind of measure of school well-being. So can we give this out and use it as a score to sort of flag where people might be needing more intervention? So that's what we're going to be doing next. So this is just a snapshot of what the assessment looks like. So it's organized under the 6 different need headings. So this is the need to be acknowledged and listened to in the right way. These kind of statements are almost verbatim from the interviews. Obviously, we've tweaked them a bit to just make them work semantically for this. So basically, it's a patient-reported outcome measure where young people can respond to these items, true for me, partly true for me, or not true for me. And the idea is that this will flag where those unmet needs are. But it will also give us something quite sensitive to evaluate interventions with. Because one of the problems that I find as a researcher is if I want to put something in place in schools and I want to evaluate it more holistically on something that isn't attendance and isn't attainment, unless I get a complex network of different measures, it's hard to have the right kind of measure. So this will kind of be able to evaluate interventions based on more holistic kind of experiences. So it might be that an intervention doesn't change attendance and doesn't change attainment, but does have an impact on how well somebody feels like they belong to the school, things like that. So this is a snapshot of that, but we've got a section for each of the 6 needs. So the final work stream that we're going to be doing for the INSCHOOL project is a national survey. So we're going to try and answer these 3 research questions using this needs assessment. So what is the impact of a long-term health condition on the school lives of young people? So we're aiming to have probably 4,000 to 5,000 young people across the UK complete this, which will give us this unique pool of national data, which should be able to comprehensively answer that question in a way that we can't at the moment. We're also really interested to know what extent participant responses vary based on their health condition and their other demographic factors, where they live in the UK, how old they are, that kind of thing. Again, that's data that we don't have access to at the moment. And is there a causal relationship between the new assessment and participants' quality of life? So we're going to be using the PEDS-QOL measure and doing some kind of correlation between the answers for the new assessment and the quality of life, with the idea that if we can improve scores on the needs assessment, perhaps we can improve overall quality of life scores. It'd be interesting to see if that is possible. So we're going to be distributing this electronically using our online surveys system. We're still working out exactly how we're going to reach 5,000 young people across the UK, but we're going to be doing it. We have a national portfolio of research nurses who work across the country. So we're hoping to use them to recruit via clinics, but we're also looking at going via kind of national charities and national distribution lists and social media. So fine-tuning the ways we're getting it out there, but we're working on that. And then I'm really interested, I was talking to Joe earlier, really interested to know if there's interest and if people think this is practically possible, to have a kind of parallel Australian national survey of some sort as well, so we can do those cross-cultural kind of comparisons. So there's an obvious missing piece of the puzzle that we have in the INSCHOOL project at the moment is I think we have a fairly good idea of parents, young people perspective and what's already out there in the research and some of the kind of clinical kind of experiences, but we don't have any evidence that says about what's currently happening in schools. So that is our big missing piece of the puzzle. So we have ideas within this puzzle piece that we're working on at the moment. So we've started to build a relationship with some multi-academy trusts in the UK. So these are groups of networks of schools. So one that we're working with has 17 high schools and 10 primary schools. We're going to be looking at building a relationship with them so that we can scope the prevalence of long-term conditions in their schools. And the idea as far as I can see, is that I think schools will know how many young people they have with cancer, but they might not know how many young people they have with sickle cell anemia or who are going to the chronic pain clinic. So I imagine that we'll find that there's a real mismatch in terms of even how aware they are of the long-term conditions in their schools, let alone how well those are provided for. So then we want to detail current support strategies, but then we also want to pilot using this needs assessment in practice. So how can we use this needs assessment to inform individual healthcare plans? I've talked about how we might be able to use it in research, but when I've spoken to young people and families, they're only very briefly involved in the individual healthcare plan process. So one of the young people I spoke to just last week said that he was asked 2 questions about what he wanted, and that was it. So the idea that they would be able to complete this 60-item needs assessment as part of the individual healthcare plans seems like it would have some value. So we want to pilot how practical that is within schools. And then we want to work with schools to co-develop some intervention materials to match the 6 needs, with the idea being that young people will complete the needs assessment, which will flag where their unmet needs might be. And schools can then go to a suite of resources to match those unmet needs with something that they can then deliver in school, an intervention they can put in place, some information they can give, that kind of thing. So we want to develop those with schools rather than developing them academically and then giving them to schools. We're trying to really avoid what happens in research a lot in the UK, which is we do our research and then we go to the practical area with a list of 20 recommendations and say, we know you don't have any resources or time, but can you do these 20 extra things? So we're trying to develop this sort of co-design way of working with schools if possible. And then we want to implement that and evaluate it. And ultimately we want to change and improve the national policy. That's the like blue sky end of the rainbow kind of thing that we want to be doing. We want to change these national policies because schools are quite often hamstrung by the fact that they have to meet attendance data, they have to meet attainment data. So we want to try and use this as evidence to sort of bring in some more holistic kind of aspects of school education. Interestingly, starting to work with schools, we've been coming across this sort of practicalities versus ideals way of thinking. So schools want things that they can deliver right now and that are really useful. So we want to do that. But we also don't want to just do everything that fits into the current school system because we think the whole system needs to change and develop. So we need to do practical things and ideal things at the same time. And we're also interested in how this maps onto primary schools and alternative provision, their future directions to go off into. How am I doing for time? Okay, that's good. So just some final thoughts before kind of open it up for some questions and feedback. So young people with long-term physical health conditions, they continue to have unmet needs at school beyond attendance and attainment. It's impossible to deny that when you talk to young people and families. Young people with long-term health, young people with different conditions have more similarities than differences, and this was something that emerged naturally from the data and not something we went in really looking for. Each condition is only a small percentage of the school population. So I think in the UK, most high schools will have 1 young person with cancer, perhaps 3 with type 1 diabetes. But actually, if you add them up all together, if you think that they have more in common than difference, and you add them all together, that's actually quite a large population of the school population that have unmet and often unrecognized needs within school. They don't flag with the same acute needs that young people in mental health crisis will do, or young people with special education needs might do. But so they're quite often under the radar. So it's a large proportion of young people. And this commonalities approach is practical and justified and more inclusive way of sort of thinking about the way we do research and the way we provide education support. I think it's also practical for schools because schools can't possibly be on top of the new developments, sickle cell anemia and cystic fibrosis. But if they have a kind of more broad commonalities needs framework, it gives them a starting point for all young people with long-term health conditions. And holistic care is what we really should be aiming for within our schools. But it's clear that we also still need to address silos between healthcare and education. So it's really challenging, I think, even as a researcher, let alone as a clinician or a school practitioner, to try and work well across those disciplinary kind of divides is still a real challenge. So these are the links to the in-school papers, but I'm happy to share them if you've got a distribution list. They're all open access, so you can see them all. And that's all the talk. So I'm happy to take questions. I'm really interested to know what people's thoughts are, what's happening currently on this side of the world, and whether this sounds very different or very much exactly what you're experiencing. I'd be really interested to know people's feedback, so thank you. I'll stop my screen share.
If there's anyone online who'd like to type a question into the chat, please feel free to do so. I've got that monitored and I can see Sam's doing that as well, but I have a mic for anyone in the room who wants to ask a question. Oh, sorry. Kate.
Can I ask 2 questions? Thanks for that. It was really interesting and very absorbing. It's a great story that's really engaging that you tell. But I guess I had 2 questions. One was whether or not, I'm not familiar with the method that you use, but whether or not you think if you'd done more of a top-down approach, whether you think you would have come up with a similar 6 themes as your starting point, and that's just out of interest. And also whether in your conversations with schools, how much resistance you're getting to this idea of the risk of just identifying needs and then asking more of an already resource challenged system, which I mean, we can relate to that. And I think we hear a lot of talk about that in schools in Australia. And I'd be really interested to hear what kind of feeling you're getting on when you're approaching and engaging with these schools.
Yeah, okay, thank you. They're 2 very good questions. So the difference between the sort of participant-led approach and the sort of top-down researcher-led approach is really, I mean, I guess it's very difficult to say what we would have found if we'd have used the alternative approach. But I think there are things that came out of the data that I don't think we would have got. But I think it's more about the dynamic of the interviews, I think would have been different. I think we'd have had potentially different uptake from participants if we'd have had a sort of researcher-led approach. I think when we were recruiting young people from the clinics, I think they were quite invested in the idea that we really wanted to hear from them. We really wanted to hear what they had to say. We designed our project around that kind of idea. So I think maybe less of the data we would have got could have been the same, could have been different, but I think the young people who we had in the study might have been different. I think the dynamics of the interview would have certainly been different. And I think we got some additional kind of depth in our interviews from the fact that young people, it was clear that we were invested in hearing what they had to say. So some specific interviews that I can think of where they brought up things in the interviews which not things that I would have asked directly about. And because they brought it up, they were happy to explore it in more depth and give me some more personal details because it felt like their own stories. I think, so it's hard to say what data we would have got different, but I think the dynamics would have definitely been different. And in terms of resistance from schools or reactions from schools, so one of the problems in the UK, and it might be the same here, is just getting into the schools in the first place is a huge challenge. So I'm definitely biased because the schools that I've managed to get in touch with and start building these research partnerships are obviously the ones who want to build research partnerships. But I think what I'm finding is that once they realize that we're not looking to just push ideas and interventions onto them, and once they realize that we are very sympathetic to the kind of resource difficulties that they're facing and we want to actively work with them from a really early stage, I think that we're getting really good engagement from the trusts that we're working with. Because we don't have any funding, so that red jigsaw piece is currently unfunded, but we're in the early stages of building the proposal, and that proposal is being built with us and the schools and healthcare. So we've got a multidisciplinary team that has school leaders, academics, local paediatricians, local council, all building it as a multidisciplinary team. So I think people are engaged with that way of doing it. I mean, I'll come back in 2 years and tell you if that's panned out well, but that's certainly what we're getting to start with.
Sounds promising. It sounds good. Thank you.
Thanks, Kate. Any other questions from the room? I might take the chair's prerogative. There were 2 things that I thought was quite interesting, but Trish, do you want to ask a question first? No. The first is around the management burden. And I know certainly that here in Sydney, in my own clinical work, and Trish, maybe you'd speak to this as well, that parents are fatigued having to do the advocacy piece. They get it. They get that it's their responsibility, but it's a lot and it's complex because the systems don't talk to each other nicely, and it can be quite overwhelming in terms of the information and knowledge that they have to gain in two quite complex areas of, say, governance and management. And whilst I think parents are responsible for advocating for their children, absolutely, how we can better support parents to say, hey, I see you, I get the burden, this is really tricky. That was sort of more of a thought rather than a reflection, but just to say that it really resonated with me. And the other piece is about the funding and how really challenging it is to get funding in this interagency space, particularly in Australia, where health sees education as education's prerogative or responsibility rather, and education sees health as health's problem. And so never shall the two consider joint, holistic, whole of health care. And I think that certainly personally resonated with my own efforts to get funding. But I did wonder about maybe community grants, and maybe it seems to me like with this new initiative you're working on is that communities are invested in looking after the people that are in their community, in their school. And I'm just curious, you know, have you had any experiences crossing those two divides and getting that buy-in, and who's saying that they'll put some cash up for it? Because that's where it comes down to.
Yeah, okay. So to go to the parents one first. So we've literally just finished the parents project. I'm writing the end of study report tomorrow. So we've literally just finished that. And what we found is that a lot of the parents who we've spoken to, they're not aware of their rights. They don't know what kind of questions to ask in schools. So they go in with a very kind of their child-centered kind of view of what their child needs, which is completely understandable. But what we've realized is that they're not aware of their rights. They don't know what kind of adjustments should be being made in school. They don't know the right questions to ask. They don't know whether it's appropriate for them to ask questions. And, you know, I mentioned in the survey of practitioners that they were unclear who had responsibility, and that's no different for the parents. Do they go to their consultant? Do they go to their schools? You know, who do they go to? So, so we're sort of going to try and translate the findings from our parent study into literally a one-sided fact sheet for parents that can be given out whenever they go to a clinic that says these are the kind of questions you might want to ask schools. Anything more than that is going to only be good for the parents who are probably already engaged enough to read a multi-page document or to go on a website and look it up. So we're trying to very light touch, high level ideas that parents can then act upon. And I mentioned about it being an inequality divide, and hopefully that kind of something that we can do to give some kind of confidence to parents who are struggling to advocate for their young people. So yeah, it's definitely a problem there. But the funding one is something that I'm definitely dealing with all the time, because as you can see from the work here, it's got a foot in academia and a foot in health and a foot in schools. We don't have many funding bodies that fund all of that. There isn't a schools and health research kind of fund. But so I'm going to funders that do have a broader view. So my fellowship's funded by the NIHR. This school's work, I'm going to go to the NIHR, which is the National Institute of Health Research in the UK. So they don't have a clinical focus, like a specialist clinical focus. We're going to go in from a sort of health inequalities, public health angle. So we're not going to go in with an education angle, even though it is education kind of applied. We're going in with the idea that this is a large cohort of young people with health conditions in the community who aren't having their needs met. We think we can best meet those needs with this multidisciplinary team partnership approach. So we think that will be appealing for the NIHR. Our parent project was funded by Leeds Hospitals Charity. So they're not disease specific. They're interested in anything that's affecting the Leeds Hospital patient community. So again, that was something where we had to pick carefully. We would struggle to get it funded by other agencies. I think there's things like the ESRC, which is very much social research. We would have to really twist the health angle to get it into there. So just being very careful how we pick and choose the charity, how we pick and choose the funders, but also our like headline message that we go in with, very tailored towards.
Thank you. I can see two questions, Jordana and Tricia. But before I do, there was one comment online. Sorry, they got in before you. Jan mentioned, what of students who do caring roles for parents or family members? They have unique pressures and family expectations and roles than other students. Is there planned future work in this space? No pressure, Simon.
So I'm just reading it back here to make sure I've got it. So yeah, really interesting group. So you're talking about young people who have caring responsibilities of their own. So we would call those young carers in the UK, and there's charities to support those young people. They are not particular students who we've covered in this project. They are one of the, definitely an interesting group who we are interested in. We don't currently have any plans to accommodate them specifically in our future work, although I would love to. I would definitely add it to the list of particular people who we would like to cover. I would be really interested to know, because I imagine they have experiences that map onto these 6 fundamental needs, but they probably have some unique ones as well with that situation. So it's definitely a good group. We don't have any current plans to investigate that ourselves, but clearly a need to investigate it.
Trish.
Hi, and Simon and I have spoken this week, but I wanted to mention that in a couple of the schools we've come across nurses in the school, and our government has a wellbeing and health in reach nurse coordinator program. So they're not full-time in every school, but they have them in selected metropolitan regional schools. So that's a really good thing. It's a joint partnership between New South Wales Health and New South Wales Education. So that's something. I also feel like our oncology children have a lot more than maybe some of the others, which is very evident. I feel like in my role, I can take some of the pressure off nurses, and parents can come back and ask me things. I think we support them really well when they're on active treatment, but then when they go back, they feel a little bit more distant. And if they still have the same people working here, or feel like they can come back and get their answers and get support, then that's handy. But I do feel for lots of the other cohorts for what they have. I find that the schools, 98% of them are very kind and just want to help. Sometimes they're going up against the education authorities and they think they have to do this. And I think for me to ask you, why is the UK so gung-ho about attendance? Because I have heard that it's a big thing.
Yeah, that's a really good question. So I think that's going to change now because we've got a new government as of a couple of weeks ago. I think the recent government we've had have been very interested on very clear deliverable metrics and data. So attendance and attainment, very easy things to kind of deliver metrics on, deliver outcomes on. The problem is for individual schools, I don't think individual teachers want to hound young people with long-term health conditions in their family to justify why they're in school, but they have to some extent, to meet these kind of attendance data quotas and things like that. Why that's the case, I don't know. And I'm really hoping our new Labour government have a different way of shaping their school priorities. But yes, that should change soon, I'm hoping. I wanted to come back to what you were saying about school nurses. So we've got a school nursing crisis, I would say, in the UK. So for example, so Leeds, where I'm based, is right next to Bradford. I work with the school nursing team in Bradford. There's 12 of them at the moment, and there's 290 schools in Bradford, and they cover all of them. But what we found in our qualitative study is that the young people who have access to a school nurse, that's huge added value for them. So I'm thinking there's a young girl with diabetes who I interviewed who had a really close relationship with her school nurse, and that was the only support she felt like she needed. That kind of mitigated any other difficulties she had in school. But she was, I think, the only person who, in that group, who had access to a school nurse, who felt like she had a relationship with a school nurse. So I think if I could provide a school nurse for every single school, some of this would dissipate to some extent. So it's a really underfunded kind of area of very important support that we don't have. And to go back to the oncology point that you made, I have definitely found that. So I'm from an oncology background. I worked in the teenage and young adult oncology service for 5 years before I came into academia. And I've been quite surprised to go around and engage with these other clinical teams to see the disparity in what young people and families have available to them. In oncology, we have multidisciplinary teams, we have large national charities, we have national kind of youth forums for oncology, that kind of thing. I know you have Canteen here, we've got Teenage Cancer Trust in the UK. But then when I went to the dermatology clinic or the chronic pain clinic, they have one consultant, or they have access to a psychologist who's part of a rota and covers lots of different clinics. And that is just hugely disparate, even within our local Leeds Children's Hospital community. So the idea that we would see these inequalities map out in these bigger experiences is not too much of a surprise. It's funding though, isn't it? It's like the oncology brings in so much funding. So.
Okay, thanks. Thank you, Simon. That was absolutely wonderful. And I love seeing the whole overarching program of work. So my question is around, we're doing some research with young people across all chronic illnesses. Okay. And the tricky point for us has been when intellectual disability is a comorbidity in there. And we're grappling with how to manage that. So I would love your thoughts. Did any of your 89 participants also have intellectual disability? And how does that then flow on with their needs at school and developing interventions? It's quite different having a young person with allergies versus somebody with, very serious intellectual disabilities as well in there.
Yeah, it's a really good question. So we had to draw the boundaries around our sample at some point. We wanted it to be as inclusive as possible. So we decided that there is mental health research happening in the UK in schools, and some of that is already making some really good progress. So we decided to just focus on physical conditions. But you're right, the intellectual kind of difficulties, mental health difficulties are comorbidities of young people with long-term health conditions. So when we were recruiting, that wasn't an exclusion criteria, provided they were able to take part in the qualitative work. Because we've got the preparation activities, that made it easier. So we had some young people who were on the autistic spectrum who were really engaging with some of the preparation activities. So the target one that I briefly mentioned felt really good for some of the people that were on the autistic spectrum, and we were able to engage with them quite well in a way that I don't think we would have been able to do, and to sit there and ask them their kind of questions. There were young people who couldn't take part because the methods didn't allow enough flexibility for them to take part within the kind of sample that we had. If we were just doing a project in one condition, we might have been able to expand those boundaries a little more, but our boundaries were expanded by the conditions rather than within the conditions to look at different types of participants. So we were aiming with this project to be as transferable as possible to lots of different young people with long-term health conditions in different contexts. So we would have needed to increase our sample quite significantly to include some of the young people that you might be referring to. So we went back and forth with that decision, and we decided to be as inclusive as we could without compromising how transferable it would be to that broader population of long-term health conditions. But like the young carers that was brought up in the chat, that's very much another avenue to explore. And I think we've got lots of potential because of the commonalities kind of approach to see how that maps out in different parts of this population. So yes and no, in a way.
Hi, Simon.
Oh, hi.
I don't actually have a question, but I just wanted to add, my name's the Deputy Principal at the Sydney Children's Hospital, just on level 0. And I just wanted to add that when we support the students that are at the hospital, we have coordinated health and education meetings across pivotal times. And during those meetings, we advocate for the parents as well. And it's a really good opportunity to raise any concerns that they may have. And it's a really important part of our transition of those students back to their census schools. And prior to this position, I was in public schools, and I've been in that role of being at the census school, and those meetings are exceptional. And with the parents' permission, and they need to sign permission to exchange information, I'm then able, within the census school, to feed that information to the teachers and make sure that those adjustments are implemented, individual education plans are completed, and just have that constant check-in with those students.
Yeah, I had a tour of the hospital school today. I was very impressed with the sort of holistic care packages you offer. I think it would be, if that was replicated in all hospitals, I think that would be a really kind of positive thing. Well, what I've found with the hospital school liaison kind of part of healthcare is that that's another oncology discrepancy. So when I was working in oncology, that was literally the role that I was in, was to go to schools and plan reintegration. There just isn't that equivalent in other conditions. So that's a huge discrepancy again in care. Because I think you're right, I think those meetings are valuable for schools to just all be there and talk through that young person's needs with the young person there ideally as well. But that's not happening in most conditions, I don't think.
So I think we're over time, just ever so slightly. I'd like to really thank Simon for coming all this way just to talk to us.
Yeah, I'd say I'm off
Yeah,
now.
he's off now. And if you wanted to have a chat with Simon about any of his work, he is around for the rest of the week, and he will also be speaking at INSCHOL and the HELP conference coming up, so in Adelaide. So please join me in thanking Simon for speaking to us today.
Thank you. Thank you.